Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for our multidisciplinary ground rounds this week, where Doctors Ryan Lett of Anesthesia, Scott Willms of Orthopedic Surgery, and Oksana Prokopchuk-Gauk of Transfusion Medicine and Hematology from the University of Saskatchewan discuss anemia, transfusion, and coagulation in the perioperative setting. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
I really appreciate this opportunity to present at these combined rounds. I appreciate that time is a bit short because there are three presenters, so I'll do my best to be efficient with time. The slides will also be available after the presentation for reference. So these are my disclosures. I've not received any financial support for this presentation. So the objectives are focused on identifying appropriate indications for ordering screening tests of coagulation in the preoperative patient, as well as summarizing an approach to interpret routine coagulation test results and determining appropriate patient care follow-up. I have a few cases infused to this presentation. So the first is a 65-year-old man who's attending a PAC clinic appointment pending an elective knee arthroplasty in 3 days. His documented past medical history includes osteoarthritis and hypertension, and the MAR shows his only prescription is Ramipril. Preoperative blood work was drawn based on the requisition, and he was provided in advance of his PAC appointment. And so GIM was one of the first to see him and was reviewing the results before going to see the patient, and this is what they see. So I'll pause for a moment. Certainly you can see that the PTT is a bit prolonged. And from a hematology perspective, certainly the first question in our mind when we get questions related to sort of the isolated prolonged PTT is, why were the PTT and INR ordered in the first place? So routine screening coagulation tests are collected in a blue top tube, if they are collected. These tubes are designed to draw a precise volume of blood to achieve a 9-to-1 ratio of blood to sodium citrate. So a properly filled tube is really important just to make sure there's accuracy of results. This being said, interpretation of any test requires clinical correlation. So although we commonly know that the PT-INR and APTT are coagulation screening tests, they shouldn't just be ordered on everybody, particularly before seeing the patient. So what's a coagulation presentation without the coagulation cascade? So this image is from Bloody Easy Coagulation Simplified, which is available on the OrbCon website for free download. Highlighting that the intrinsic pathway include the coagulation factors that are tested in the APTT, while the extrinsic pathway, so specifically factor 7, is assessed in the PT-INR. Both tests assess the common pathway, so if you have an isolated elevated APTT or an isolated prolonged INR, you know that it's not a problem in the common pathway, because if it's a problem in the common pathway, both of these screening tests end up having a prolonged result or an abnormal result. So understanding which factors are involved here are really important. I'll also highlight that the coagulation cascade really focuses on secondary hemostasis. Of course, we think about hemostasis as primary, which includes your collagen, your von Willebrand factor, as well as platelets. And then secondary hemostasis, which predominantly involves the coagulation factors. And just a reminder that the PT, INR, and APTT don't at all look at primary hemostasis. I do have some reference slides at the end of the presentation, as well as some video links that help to visualize the coagulation cascade, because it is very dynamic and complex. It's not just this nice linear pathway that we see on the screen. So there are some resources here for additional reminders of how the clotting pathways work. So the original intent of why the PT-INR and APTT were developed are really important to know, just to understand perspective of where these tests came from. So the INR was originally developed to assist with titration of warfarin, and INR itself stands for International Normalized Ratio. It's a calculated value that's designed to facilitate cross-lab communication of the degree of warfarin-related anticoagulation for ambulatory patients. So the PT is actually measured in seconds, but it's the INR that's calculated to give this standardized reporting. So when we're looking at an INR and interpreting it outside the context of warfarin-related anticoagulation, it's outside of the original intent of the test. Similarly, the APTT was initially developed to assist with diagnosis of hemophilias, and it's actually designed to be normal with a factor 8 or 9 level greater than 40%. So clinically significant coagulation factor deficiency may be present with a factor level of less than 50%, right? In that 40 to 50% range, your PTT may be normal. So relying on the lab tests alone may actually lead you to miss an important bleeding disorder if the history is not considered. So in the contemporary era, the INR and APTT have been inappropriately repurposed to screen for coagulopathies in low-risk patients in the pre-op setting. So the underlying message is we as a system need to stop doing this. I really love this graphic, and it's from this bottom reference here, which is an illustrated review of coagulation testing and bleeding assessment tools. Many more images within that paper, so I'd encourage you to consult it if you haven't seen it before. But basically, one of the Choosing Wisely statements that was published by the Canadian Anesthesiologist Society several years ago was not to order baseline coagulation tests for asymptomatic patients having low-risk surgeries. There are studies that have supported this statement, namely that there was a study from 2012 identifying that the PT and APTT had a sensitivity of 1 to 2% for ruling out a bleeding disorder. So it's terrible because good tests that are screening tests need to have a high sensitivity, sort of in the greater than 70% range. So to have a sensitivity of 1 to 2% is awful. So a normal PT and APTT certainly does not rule out the presence of a bleeding disorder. And subsequent investigations through retrospective review published in 2015 identified similar results, where patients who had these screening tests of coagulation, when a deeper dive was done in terms of their clinical profile, over 90 to 99% of those tests were considered to be inappropriate. So when do you actually order screening tests for coagulation? Well, you can consider it in patients who have vitamin K antagonists ongoing, like warfarin, who have liver disease. Certainly, INR is one of the ABCs of liver function, right? Albumin, bilirubin, and C is coagulation. So ordering an INR in that setting is very reasonable. And then patients at risk for vitamin K deficiency due to a variety of underlying clinical conditions. You can consider an APTT if there's planned intraoperative IV heparin, like in cardiac or vascular surgery. If, based on a history, there's suspected hemophilia or factor 11 deficiency or severe von Willebrand disease. So severe von Willebrand disease will also have low factor 8 levels, which is why that one's listed. As well as suspected antiphospholipid syndrome. So I'll be talking about this in a couple of slides, but remember too that a prolonged APTT isn't just associated with a coagulation factor deficiency, but may also be associated with antibodies that lead to interference with the testing and have nothing to do with a bleeding disorder at all. So top 5 reasons not to order a PT or APTT is routine blood work, routine pre-op screening in low-risk patients, monitoring DOACs, so your rivaroxaban, apixaban, edoxaban, no purpose there, monitoring low molecular weight heparin, as well as thromboprophylaxis. So once again, and this is not news, but history is the best test for a bleeding disorder. in general, there are patterns that we can identify in patients with bleeding disorders in terms of how they bleed. So disorders of primary hemostasis, so again, issues with the collagen vascular system, platelets, or von Willebrand factor, typically have a mucocutaneous bleeding pattern. So mucous membranes, cutaneous, skin. So if you think about the skin and mucous membranes, these are the surfaces where patients typically bleed. And if there are disorders of secondary hemostasis, particularly severe ones, these are coagulation factor deficiencies that often have more of a delayed bleeding pattern with musculoskeletal bleeding symptoms, so muscle hematomas and joint bleeding. I'll bring your attention to that medium green triangle at the bottom of the figure in the sense that there is a lot of crossover. So patients who have severe disorders of primary hemostasis will also have musculoskeletal bleeding symptoms. And patients with mild disorders of secondary hemostasis, so like mild hemophilia or mild von Willebrand disease, sorry, I shouldn't say von Willebrand disease is a primary disorder, but mild hemophilia just with isolated factor 8 or 9 levels in that sort of 20 to 30% range will also have mucocutaneous symptoms. So just be aware that it's not absolute in terms of primary disorders only having mucocutaneous symptoms and coagulation factor deficiencies only having musculoskeletal symptoms. There's definitely crossover. So bleeding assessment tools are standardized to take a detailed bleeding history and guide appropriate testing to investigate a bleeding disorder. So you can see here that the published bleeding assessment tools do have fairly high sensitivity in terms of ruling out a bleeding disorder. The test that we use, or the bleeding assessment tool that we use in the Saskatchewan Bleeding Disorders Program, is the condensed MCMDM-1 bleeding assessment tool that's been validated for von Willebrand disease as well as platelet function defects. The self-BAT is an interesting one, and I'll just highlight that one for a minute, because the self-BAT's actually designed for a patient to go through the questions and actually receive a score at the end based on an online tool as to whether there may be a concern of a bleeding disorder that could then potentially lead them to discuss these results with their family physician or with their internist and actually request a referral to a hematologist, or conversely, a healthcare provider could ask them to do a self-BAT. So questions within these bleeding assessment tools, again, really focus on both the mucocutaneous as well as some of the musculoskeletal related bleeding sites. So these include like intracranial hemorrhage, hemarthrosis, and joint bleeds, the muscle hematomas as well as joint bleeds, sort of as the more severe signals of bleeding. But mucocutaneous symptoms are things like bruising, bleeding from minor wounds, epistaxis, oral cavity bleeding, GI bleeding, heavy menstrual bleeding, and hematuria. A lot of people really don't understand what heavy menstrual bleeding is. So there's a mnemonic here that's very simple. PEER, so if patients are passing large clots, they're taking 1 hour to soak a super absorbency product on their heavier bleeding days. If the bleeding is lasting for more than 7 days, or if their menstrual bleeding is actually restricting activities, like preventing them from leaving the house due to the flow heaviness, or preventing them from doing sports or participating in sort of usual activities, those are signals that periods are too heavy. Hemostatic challenges are really important to assess for as well, especially prolonged oozing after tooth extraction, if there was any degree of postpartum hemorrhage, as well as if there's any either immediate or delayed bleeding after surgeries. And I'll also just remind everyone that patients with mild bleeding disorders may have mucocutaneous bleeding symptoms that they kind of deal with, and just bleed badly after the hemostatic challenges, right? After the extractions or the surgeries, they may not actually have significant bleeding on a day-to-day basis, which is why many patients with mild bleeding disorders can sort of say, oh yeah, it's there, but doesn't really affect me. But they may forget that it doesn't affect them because it's mild, and it will affect them in the context of a surgery. Just some links here in terms of the bleeding assessment tools, if anybody's interested. One major limitation of the first 3 listed is that they need to be administered by a healthcare professional. There is no standardized bleeding assessment tool that's been validated for use in the preoperative setting. However, our colleagues in Toronto are completing a study looking at whether the self-BAT can accurately predict perioperative bleeding. The goal recruitment is 1,800 patients. The lead investigator is Dr. Michelle Scholzberg, and I just spoke with her 2 weeks ago, and she said they're past 50% enrollment. So I'm hoping that this publication comes within the next 1 to 2 years to help us all be able to have a useful bleeding assessment tool for the PAC setting. So without a validated tool for PAC, what do we do? So there are some suggested questions in terms of an approach just to get a snapshot of what a patient's bleeding profile may be like. So for instance, in the sense of personal bleeding, what's the onset of bleeding, if any, has occurred? Is it after dental extraction or surgery? Is it right away? Or is it sort of after 3 or 4 days, more of a delayed character? Is it spontaneous? Again, the joint bleeds, or traumatic bleeding that led to a physician visit and need for intervention. And spontaneous can also include not just the joints, but nosebleeds. Like some patients with bleeding disorders have horrible spontaneous nosebleeds that bring them to the emergency department that require packing or cautery. What's the location and pattern of bleeding? Is there a history of anemia or iron deficiency requiring treatment? Has there ever been a history of blood transfusion? So if there's a history of blood transfusion due to some kind of bleeding or iron deficiency, that right away is a major positive flag. And then any anticoagulant use, bleeding does not just have to be from a congenital bleeding disorder. Is there an anticoagulant present that's actually contributing to the bleeding issue? And then very, very importantly is a family history of bleeding disorders, because of course, congenital bleeding disorders run in families. From a physical exam perspective, are there any issues or abnormalities in the vital signs related to anemia? Do they have any signs of pallor? And conversely, if there's a hemolytic disorder leading to anemia, which is not bleeding disorder related, it could be jaundice. Or further, if there's liver disease, there could be jaundice. What's the size and location of bruising, petechiae, hematomas, or even any telangiectasias? And then finally, the oral mucosa can be very telling in terms of if there's any gingival oozing or petechiae in the mouth. Certainly that's more related to a platelet function disorder or even low platelets like ITP. And then the joints. Is there any restriction in range of motion due to suspected hemarthrosis? So if there's ever any concern of a bleeding disorder on history or physical exam, please delay the case and refer to hematology for the sake of safety. I know surgeons hate this when there's this question, should we delay? Can we not just go forward? The healthcare system needs to sort of work like a machine in many ways, especially when we need to get patients through the operating theaters. But if there's any question of safety and if there's some spidey sense going off saying, I don't know, this just doesn't feel right, call one of us, call a hematologist to discuss the case, because it's always better to ensure the patient is safe than risk some kind of a bleeding complication thereafter that could have been avoided. So we're still back to this first case where there's the prolonged APTT. The internist does a bit more of a deep dive into the history and finds out that the history is quite benign. There are really no flags on the bleeding history, and there's no history of anticoagulant use or history of thrombosis that might signal antiphospholipid antibody syndrome. So now what do we do? Where do we go from here? Historical lab review can be really helpful just to give perspective on whether that prolonged PTT is new or not. And in looking at this patient's history, there is a single reported PTT of 43 seconds from a couple of years ago. So ultimately, the question is this a factor deficiency? Well, the history is really not suggestive of that. Or is there some kind of an inhibitor causing a prolonged PTT? So the next step is to do a mixing study just to confirm your hypothesis in terms of this looking more like an inhibitor rather than a factor deficiency. So a mixing study basically takes one part of the patient plasma and takes another part of normal pooled plasma from the lab. There's a 1-to-1 proportion, so a 50% to 50% mix of these volumes that goes into a tube, and then there's an assessment of the PTT or INR to see what the result of the mixed sample and normal pooled plasma will be. If there's full correction, again, knowing that the APTT is designed to be normal with a minimum of 40 to 50% factor present, if there's correction of the APTT, this suggests a factor deficiency. Remember that a prolonged factor 12 can certainly, a prolonged APTT can be due to a deficient factor 12, but that's not necessarily associated with bleeding. So if there is some signal of correction after a 50-50 mix, it's definitely appropriate to do your individual factors to figure out, well, which factor is low to actually cause this prolonged APTT. So in the patient case presented, that could be a signal of factor 12 deficiency, for example. Even with a completely negative bleeding history, that would be expected. Conversely, if there's an inhibitor present, this means that there's some antibody floating around in the patient plasma that's actually interfering with our testing in the lab. So we classically, when we think inhibitor, we think, oh, like factor 8 inhibitor, like this must be really bad. Well, okay, true. Like a prolonged APTT can be because of an anti-specific factor inhibitor, but those patients bleed. Like clinically, they will have bad bleeding that kind of arises relatively acutely over a period of a couple of days or weeks, and then are presenting and they look like they've been beaten up. They bleed terribly. So in this case, we have a prolonged APTT, and we have sorry about that. If you have that prolonged APTT and there's some kind of an inhibitor against phospholipids in the patient plasma, this will also interfere with the testing. And so that has nothing to do with a defined antiphospholipid antibody syndrome, but it certainly may just be there because it's interfering with the testing. So this is your antiphospholipid antibody that isn't truly antiphospholipid antibody syndrome. So in this case, patient with a negative bleeding history, let's do a mixing study. So we do a mixing study, and the normal pool plasma, which has a normal APTT mixed with the patient plasma, has once again resulted in a lack of correction. So it's the one-to-one mix is very near to the result of the patient plasma, which tell us that there is inhibition present that is preventing normalization or correction of that result. So I often get the question of, well, what's considered a correction and versus not a correction? So the rule of thumb is if the one-to-one mix is within 3 seconds of the original patient plasma result, this is considered inhibitor interference. And if that's combined with a negative bleeding history, that implies that there's a non-specific inhibitor present, not a factor deficiency. So there's no increased bleeding risk in this patient. And further, there's no increased thrombosis risk. Again, it's not directly associated with antiphospholipid antibody syndrome. So a patient like this can proceed to surgery without any bleeding risk. I have 2 more very brief cases. So a 19-year-old woman is pending surgery to correct major symptomatic scoliosis. She has no known medical diagnoses and has never had any other surgical procedures or dental extractions. Her only medication is an estrogen-based oral contraceptive pill. Her family history is significant for mild hemophilia B in her father. On further questioning, she says that she has nosebleeds that can last more than 10 minutes at worst. She has previously developed iron deficiency due to heavy menses, but this has resolved with use of oral iron, as well as the continuous use of an oral contraceptive pill. So these are her labs, notably an INR 1.0 and an APTT of 35 seconds. So the coags are normal. Great. So does that mean we can proceed straight to surgery? So again, running short on time, I'll just proceed with the presentation, but I'm sure most of you gleaned that there are red flags in this history. There's a suspicion of a bleeding phenotype with epistaxis being greater than 10 minutes with each nosebleed, heavy menses causing iron deficiency requiring intervention, as well as a positive history of hemophilia B in her dad. We find out too that the dad is followed by the Saskatchewan Bleeding Disorders Program, and he has a baseline factor 9 level of 20%. So the crux here is that daughters of hemophilia men are obligate carriers of the factor 9 gene mutation. And so women can have mild hemophilia as a result, just based on expression of the X chromosome and incomplete or skewed lionization or X inactivation, which can occur. So if more of the normal X chromosome is inactivated as a part of that random process during embryogenesis, then women can actually have symptomatic mild hemophilia. So when we check her levels, her factor IX is 40%. And recall that she had a normal PTT. So the surgery needs to be delayed. The patient needs to be referred for a perioperative plan, and now has a diagnosis of hemophilia B. So if there are signals on the bleeding history, just remember to not ignore those. And very briefly, the last case too is a 54-year-old man with known von Willebrand disease pending a knee arthroplasty for osteoarthritis, has a significant bleeding history, is followed by the bleeding disorders program. He has routine blood work drawn in the pack, and again has a normal INR and ABTT. But the point of this case is to demonstrate to you that, you know, the normal PTT here correlates with a factor VIII level of 40%. These patients, especially with type 2 von Willebrand disease, can have profoundly low von Willebrand factor activity that is absolutely missed by screening tests, because von Willebrand factor is not considered as a part of the PTT or INR. So just remember that the bleeding history is imperative, and especially finding out if there's a previous diagnosis of a bleeding disorder or any family history, because this patient would be a nightmare in the OR without any von Willebrand factor therapy before the surgery. So that takes me to the end. I'm happy to take any questions if there's time. Otherwise, the slides will be circulated, and I can always take questions by email if there are any. Thank you.
Does anybody have any questions here while we get Scott to come down? There are two quick ones just on the chat. Pre-op screening tests have any utility other than classic coags? And then what do you do in the mixing studies or halfway correcting? And then Dr. Mateen has a question after. So.
Okay. So the brief answer to the pre-op tag is, why are we doing the tag? So, I mean, with any test, there's a cost. The tags are not cheap. And currently the tags are run by the core OR, as you know, and they have to be manually run by the perfusionist. There are reagent costs associated. So although they can give a snapshot of sort of the whole blood milieu and what's happening, it's not the be all and end all. I actually was just involved in a case recently, post-cardiac surgery. The tag was flagging that the patient may need extra factor replacement. The patient had already received 2,000 units of PCC in OR as a part of the cardiac surgery. So, and they said that there really wasn't any oozing, but the tag said, and I asked them to run conventional coags, and the PTT and INR are normal. So just remember that the tag is kind of a shotgun approach. You have to take the tag results in the context of the patient as well, because no test has that 100% certainty in terms of screening a bleeding disorder versus not. It's the history that really has the deepest value of information. The challenge is it takes time, right? Like, you actually have to take the time to ask the questions. And then mixing studies are halfway correcting. So I'm not exactly sure what that means. I think what that means is when, like, the result of the mix is that it doesn't return completely to normal. If that's the case, basically, if the test doesn't normalize completely, it does show that there's some kind of interference there, either from an antibody. Well, predominantly it will be from an antiphospholipid type non-specific inhibitor, because truly, if there is a factor deficiency, you will have that correction. So one needs to, again, look at, are there any medications that are interfering? Often we will see sort of this half correction if there is some kind of residual oral anticoagulants or other anticoagulants on board. But if there are these studies that are a bit more gray, you can always phone a hematologist or the transfusion physician on call to help with interpretation. But again, at the same time, it just brings everything back to, why was the test ordered in the first place? So I think that's really what the teams here need to look at, is when is it okay to order these coagulation tests? so that they're not just blanket ordered on everybody, and we're not then running into doing extra tests to investigate for a quote unquote problem that's been detected that really was inappropriately assessed in the first place.
My part will be very quick here. I don't think anybody came to listen to a surgeon talk about anemia, and no surgeon wants to be associated with bleeding. So we'll just move on here pretty quickly. Move to the next slide there. These are Ryan Lett's disclosures, and I have none, and I am very boring. Next one's going to be just our objectives. So we'll talk about, I'm just going to talk about some of the specific kind of preoperative and intraoperative concerns and some of the things that go through our mind when we're kind of before surgery and maybe during surgery. When we're talking on this topic, and then Ryan's going to answer 2 and 3 there. So first, I'll introduce 2 cases, and then they'll be answered throughout Ryan's presentation there. So the first one's a 22-year-old female who's got a traumatic femur fracture, otherwise healthy, had a hemoglobin of 65. The previously was 115. Heart rate's 85, blood pressure's 105 on 70, urine output's 0.5. The plan just for operative fixation within the next 24 hours. And then the questions that just everybody can think about is, what is the optimal transfusion strategy for this patient? Is it different than an elderly patient? And what other management would be considered ideal? I think when I approach that case, I'm automatically thinking transfusion. I can say that for sure. That was my answer right off the bat. And that's not the right answer, as we'll find out. So it's good to kind of think about that. And then case 2, which is much more common, is going to be a 78-year-old female with an extracapular femur fracture, has hypertension, mild dementia, lives at a nursing home, had a hemoglobin of 91 today, and previously was 103, heart rate's 85, blood pressure is 105 on 70, and urine output's 0.5. And again, we're planning on operative fixation within 24 hours. And so what's the optimal transfusion strategy for this patient, and what other management might be considered ideal? So some of the concerns that that I'll just touch on a little bit is, how much blood loss will we kind of incur, like perioperatively and intraoperatively? We get asked that question sometimes. Even recently I was in the OR and somebody asked me at the beginning of the case, what would I expect? So I'll talk about that a little bit. And then, will the blood loss be affected by certain patient comorbidities and anticoagulation? We know perioperative anemia increases morbidity, mortality, and hospital stay, but how do we address this? And then, what hemoglobin number is too low? And the other thing that crosses through our mind, and as a joke I put this, but honestly, it's like, will things get canceled? And we don't want things to get canceled, right? When I hear I'm not supposed to order an INR and a PTT, yet we're planning on doing neuroaxial, anesthesia on a lot of patients, that's the first thing that goes through my mind, is like, if I don't order that INR, what's going to happen? So these are some of the things, and I think that I'll just touch on there a little bit more. But for estimated intraoperative blood loss, I don't think it would come to anybody's surprise that we suck at estimating, right? Again, I think it's maybe a little bit, we have no idea. Maybe it's a little bit of ego. We want to think that, we do a good job and not losing blood. But I think what we know is that we're doing a terrible job of it. There's this eyeball method where you basically look at the floor, you look at your scrubs, maybe you look at the sponges, you look at your canister, and then you half it. And, when you're at like, 200, and they probably lost like 700 or a liter, but we just have no idea, right? So that's kind of part of it. Many studies have basically concluded that we're very inaccurate and unreliable. And then we also don't really know some of this is due to just hidden blood loss. So stuff that's lost into the tissues that we never see. And then stuff that's happening after even you're done. Like recently I was just again doing a case where I fixed an acetabulum. Hemoglobin was 73 at the time of closure. We repeated it, and the next day on the OR it was 63, right? So that's just stuff that's going to happen afterwards and things like that that are occurring, or that hidden blood loss that you don't always see. So I think that's part of the reason. Next slide will show just the examples of what some of the average blood loss, just according to some of the studies there that show. You can see total knees and total hips. Total hips consistently are more than total knees, about 1.5 liters, which is probably about 25% of your blood volume, pretty substantial. From the trauma side of things, I just put up a couple different, just where there are studies that showed preoperative hemoglobin to postoperative hemoglobin. the thing that struck me on this when I looked at this list is a lot of these were very low, especially when I looked at the spine one. And I don't know who they necessarily paid off for that, but I mean, a drop of 8 is pretty crazy for a spine surgery. Most of the time, you're going to see that more. But even things like, again, these numbers were just consistently lower from what I would expect for somebody to lose, I guess, in there. And maybe that's explained by the next slide when I put up the next slide here and show you that a lot of the factors are due, you know, to certain things like this. So you see the veterans like Pally and the rookies like me, maybe that's partly why I'm seeing lower numbers. But the bigger things are going to be like a lot of factors kind of impact what we're doing. And I don't think you can estimate that, right? So when you get like, again, another case, I did a total hip on somebody and removed some hardware and they had liver failure and an INR preoperatively showed that it was normal. And then the next day it was 2 and they bled into their soft tissues a ton. And now, you know, and then, so that like, it's hard to account for that. And the entire surgery was bloody and losing lots of blood. So you just don't know. And that's the hardest thing I'd say at the end of the day. We have no idea how much blood we're going to lose, I think, when it comes down to it. And so we can do our best guess and our estimate, but at the end of the day, we don't know and things can go wrong. And stuff like that too. And so I think that's what kind of makes us nervous when we have a low hemoglobin. You're looking at it and thinking, you know, like, I don't know what's going to happen during the surgery. We might as well just transfuse to be safe, right? And so that's a lot of, I think, what's going through our minds. The one thing I do want to touch on is that on that last slide, I just talked about anticoagulation being, you know, something that will cause maybe more bleeding. And I mean, that makes sense. One thing I did want to touch on is this recent study from the orthopedic trauma journal, basically, that says they asked this question, like, you know, does preoperative anticoagulation predict transfusion risk? And I presented this a couple years ago, but I consistently see on the ward, you know, when I'm doing the ward, that we're often, you know, we're trying to hold people for 48 hours or 72 hours off their DOACs. And I think that's obviously true if they need a spinal. I think that that's been proven. But when we're talking about general and we're trying to get hip fractures in under 48 hours, they've done studies on this that have basically showed that delayed management is actually what causes more of the problem, not the anticoagulation. So basically, this study was done on 205 patients at 82 of the mean age, and they were just looking at people on DOACs that were treated within 48 hours versus after 48 hours for a surgical delay. And they actually found that the delayed surgical management were more likely to require the transfusion and significant longer stays. So basically says that we shouldn't be delaying patients who are on DOACs. We should just proceed to the OR. And that's slowly started to change a little bit, but I just wanted to make sure that was highlighted again. And then the last couple slides here, basically, it's well known that this is going to increase, like anemia is going to increase morbidity, mortality, hospital stay. Morbidity kind of includes cardiovascular events, but also causes surgical site infections. So I think it's definitely something, you know, in elective procedures that should be delaying patients so that that gets optimized. Transfusions also independently increase this risk as well. So it's not always the best strategy. And so I think that will help as we listen to the rest of the presentation. But I think some of what's also is we often feel that there's nothing else that we can do quickly to change that. And that especially comes true for a trauma, you know, when we're on the ward. Like there's nothing that we can do quickly to change somebody's preoperative hemoglobin. And so then we just, you know, figure that transfusion's our best bet and let's do that and then get them to the OR. And so I think some of the rest of this presentation will help clarify that. And then the last one was just on the piece just around like, you know, what's the magic number? What's going to get them into the OR? Those sort of things. And I think we often feel the pressure of just transfusing once the number below 70. And part of the reason I think, to be honest, is that we like hard and fast rules, right? Everybody likes black and white. I don't want to make another decision. So if it's 69, okay, they get a transfusion. It's below 70, right? That's kind of some of the thinking I think that drives that. It's often easier to just transfuse than ask for help. We just kind of want to get on with their day, so we'll do that. And then we also don't really want our patient to get canceled before surgery. So we just do what's the safe and kind of move on. And I think that's what drives a lot of that. And so when I think about what the solutions are, sometimes these problems is more standardization again. And I think that's the big thing that I heard, you know, even previously from Oksana's presentation too. But if the more that we can standardize things and adhere to those rules, I think it definitely helps us on our end to be able to figure what the next steps are. So With that, I'm just going to leave these kind of were my biggest questions at the that I kind of remained after I thought about that. And it mainly had to do just around, what is our magic number? What should we be doing? And like, what can we do to optimize that if we can't use transfusions? And what is the timing that sort of does that? So I'll leave with that to Dr. Lett, who will go through the rest of everything.
Okay, so I actually just flew in from France last night. So I thought it was a good idea to do a presentation right afterwards, and we'll see how that goes. But I'm feeling pretty good this morning. We had a good flight and everything went as planned. But while we were in France, one thing that was really funny is that all of these old Monty Python skits kept coming up, and you see it when you start seeing history, and it's even funnier when you understand the context when you're there exploring it. So this is a classic Monty Python sketch where they're collecting the dead at the time of the plague. And the one guy says, "Bring out your dead." And the elderly one being shouldered by someone else says, "Well, I'm not dead yet." And the response is, "Oh, but you will be." And then the man carrying him, or the man being carried, says, "I think I'd like to go for a walk," which sounds a lot like our orthopedic patients. And it's funny because it's actually a binary choice. You're alive or dead, even though we know that life is really a continuum. So he may have been ill, but he wasn't dead yet. And we often treat anemia the same way. And we often confuse anemia with transfusion. So it becomes a binary choice again. So I'm not anemic yet because I'm not transfusible yet. And as practitioners, we use our powers of prediction and experience, and we can often say with reasonable experience, well, you probably will be. And of course, we give 1 unit of blood. Although that's a new thing in Saskatchewan, because if we looked at how our practice has changed over time, prior to 2016 and 18, we were using 2 units of blood. So most of my slides are numbered in terms of by number of tools. Red blood cell transfusion is still a tool. I didn't want to put it on here as the number 1 tool because I think it's probably should be used as the tool of last resort. So it has the shortest duration of effect. It's best thought of as a Band-Aid. It's immunosuppressive, which has implications for cancer and infection. It suppresses hematopoiesis, but it still is effective when there is no time, no volume, and you have active hemorrhage. Interestingly, the most common cause of death related to transfusion is transfusion-associated circulatory overload. And the fastest way to get somebody circulatory overloaded is to have somebody who's already volume replete and then give them a unit of blood. So most guidelines have come out. So the Cardiovascular Society, Gynae Oncology, and a couple of others have all come out saying there's really no role for preoperative transfusion in volume replete asymptomatic patients. So the AABB just published brand new guidelines in 2023, which didn't really change that much from the previous one in regards to orthopedics. So they reaffirmed that the cutoff in orthopedics should be 8 grams per deciliter for patients undergoing orthopedic surgery. But when you read through the paper, they actually said they were able to come to consensus for all of these recommendations, except for different restrictive thresholds by clinical subgroup in which they voted on it. And the problem is that when you look at the panel of people involved, all of them are very bright, all of them have really good backgrounds, but surgery is underrepresented, as is, for that matter, anesthesia. And so it's possible that the voice of the surgeon gets lost when these guidelines are being written. The other thing that's interesting is when you take a look at what they based their recommendations on. So they included 6 trials from the hip fracture population and 5 trials from the arthroplasty population. And all of them were elderly patients. So when you apply a broad spectrum across an entire population of patients, you have to take into account the underlying patient patient factors. And the interesting thing is they actually included one study here on pre-autologous blood donation, which isn't even practiced anywhere in North America anymore. And yet they still included it in their guidelines. They also included at least one retrospective study, which is interesting because there's a lot of retrospective studies, and I don't know why they picked this one compared to other ones that have also been published. The studies looked at a variety of outcomes, mortality being most common, but also troponin use, ECG changes, delirium, and ambulation. And essentially, there was no difference between the 80 gram per liter and 100 gram per liter thresholds. However, none of these was a dose-finding study, since they were all a more versus less study. So while we can be confident that there is no difference between 80 grams per liter and 100 grams per liter, we're not actually sure whether current practice is optimized to the patient in front of us. There is a review paper specific to femur fractures. And first of all, as Scott mentioned, it should come as no surprise that patients with anemia do worse than patients without anemia. So anemia increases mortality. This is across all studies that have ever been done. Interestingly, transfusion also seems to increase the risk of mortality. Now, I don't have a slide from the orthopedic population. I have some from cardiac surgery, and this one is from pediatrics. And it just does a nice job of illustrating what actually happens. So a non-anemic patient has the lowest risk of, this is actually mortality. An anemic patient has an increased rate of death. A not anemic patient who's transfused has about the same risk of death as the anemic patient who's not transfused. But when you combine anemia and transfusion, you actually see a 4-fold increase in the rate of mortality. And we often look at, as Scott alluded to, transfusion is probably a lot more complex. And one of the reasons I've enjoyed working with Oksana and other hematologists from across Canada is that you learn a lot as you do this. So the goal in a complex system is to have the patient come out looking like what they did before. When we use an oversimplified system, you can almost guarantee the results are not going to be the same as what you had before. The more variables you account for, you might get closer. And this is where I think AI is a really promising venture, especially in clinical decision-making. But the reality is if you're not using the same thing as the patient started with, you might still arrive at the wrong destination. So with red blood cells, what we think we're transfusing is the textbook picture of red blood cells. What we're actually transfusing, however, is that after blood has been taken out of the body and stored for a while, is a lot of the structure of the cells have changed, the chemical composition has changed, and ultimately you may not actually be delivering oxygen to the tissues in the same manner that you thought you were if blood actually looked the same way as it did when you took it out of the patient in the first place. Another fascinating aspect that I didn't know when I started reading and working with the blood community is that the concentration in your blood vessels changes depending on the vasculature. So in the capillary bed, it's actually usually a constant between 35 and 45 grams per liter, no matter if your larger venous or arterial beds are 70 grams per liter or 150 grams per liter. And this is a simple matter of physics, actually. In order for blood to flow down the small vessels, it must have a minimum amount of plasma, which leads to a lower concentrations of hemoglobin in the capillaries. The assumption is always that more blood always equals more tissue oxygenation. In critical care studies, we have successfully shown that when you give a blood transfusion, your hemoglobin goes up, and we pat ourselves on the back. And for the most part, this also means that there's more oxygen being carried in the blood, so the delivery of oxygen. But when you look at the VO2, so the consumption of oxygen, it looks like actually a blood transfusion doesn't increase the rate of oxygen that tissues can use. And when you look at end organ markers of cellular oxygenation, oxidative respiration, there's probably no effect whatsoever as far as oxygen uptake. So the problem with a lot of these studies that we've done, comparing 80 or 70 grams per liter for 100 grams per liter, is that none of these address the question of when hypoxia actually occurs at the tissue level. So we know that there is a level that this will suffer, but it's actually in that 35 to 45 grams per liter, which is the same level that your capillaries regulate blood to. The Bloody Easy document that Oksana alluded to earlier actually has a paper in there on pediatrics specifically that says that pediatric patients in particular, if the etiology is iron deficiency, they're probably fine down to hemoglobin of about 35 grams per liter, which jives with our physiology. The debatable range right now is probably in that 50 to 70 grams per liter range. And this is where the studies are starting to move towards. And then in that higher transfusion threshold range, it's a probably not. There might be patient factors that change your mind, but it's most of the time probably not. When we compare other options that patients have, IV iron is probably beneficial up until they start to develop markers of cellular hypoxia. Oral iron probably works with enough time and is probably best reserved for the outpatient setting. And then erythropoietin stimulating agents are actually probably synergistically beneficial with any other tool that you use to try and improve hemoglobin levels. And the timing changes as well with these. So blood transfusion, you get that immediate rise in hemoglobin, but it suppresses erythropoietin. It's expensive. And if the patient's hospitalized for a long period of time, it probably is going to need to be repeated. A complete whole body dose of IV iron costs about the same as 1 unit of red blood cells, but you get a 3-fold increase in hemoglobin. It's just going to take you a little bit longer to get there. So the first day, you're not going to see a difference. It's probably going to take you between 7 and 14 days before you start to see a rise in hemoglobin. And where you really see the benefit is after that 30-day mark. And again, oral iron works if you have time, but it assumes the patient has no inflammation, which isn't true in our surgical population. So I've heard a lot of variations of blood product consent over the years, but there's a lot of things we don't generally include in our informed consent on blood products, with the exception of some comment on viral or unknown pathogens that might be in the blood system and transfusion reactions. However, on a case-by-case basis, mortality is higher, spontaneous and recurrent cancer is higher, surgical site infections are higher, organ dysfunction, including renal injury, lung injury, thrombosis, and rebleeding, as well as alloimmunization, are all higher in the transfused population. And we don't generally tell people that, I think in part because transfusions are default mode of therapy for anemia. So here's a study in otherwise healthy young women who received an on-label indication for a blood transfusion during a postpartum hemorrhage. And again, there's a small but increased, in a dose-dependent manner, of increased risk of new cancer diagnosed in the next 8 years, including brain, lung, and ovarian cancer. It's retrospective, so you can't prove causation, but it's still worrisome. This is an excellent article from Anesthesia, and they looked at all of the cancers that are out there. And what's worrisome is all of the most common forms of cancer actually have higher reoccurrences if the patient is transfused at the time of their operation. The one relevant to orthopedics is that at least bone metastases do not seem to get worse if there's a transfusion at the time of surgery. Thrombosis is also relevant in a dose-dependent manner. However, it is rarely disclosed to the patient. In comparison to erythropoietin use, because we don't usually compare therapies, 1 unit of blood doubles your risk of thrombosis, 2 or more units triple or quadruples your risk. The risk of thrombosis due to erythropoietin in cancer is about a 1.5 to 1.7-fold increase when you are on the medication for a prolonged period of time. However, in the perioperative arena, a short use of 2 to 4 weeks, there does not appear to be an increased risk of thrombosis. And yet it is a complication of the drug that will be disclosed to the patient starting the medication and not disclosed to the patient receiving a blood transfusion. Quick background on infection, transfusion, and IV iron. So this study was in cardiac surgery, and compared to baseline, the IV iron group actually had a lower infection risk compared to baseline, whereas any group, whether it was combined with IV iron or not, had a higher risk of perioperative infection. And there are probably 3 issues at stake here. So one is that blood, especially hemolyzed blood, contains free iron and can act as a medium for bacterial growth. Blood transfusion can suppress the immune system. And if the patient has iron deficiency, their immune system actually doesn't function as well, which may be why we see a reduction in infection in the IV iron group. This paper from 2009 was more than 2 million arthroplasty patients, and they showed transfusion to be associated with all complications of medical care, including device complications, thrombosis, and again, infection. And again, in elective arthroplasty, patients receiving a unit of blood seem to be at increased risk for perioperative surgical site infection. So now we're going to individualize risk a little bit based on age. So this is the newest randomized controlled trial to be published in a non-elderly orthopedic population at 3 US trauma centers. They randomized patients younger than 50 who had a primary orthopedic injury. They had to be clinically stable and no longer requiring active resuscitation. And they defined their restrictive group as 55 grams per liter and their liberal group as 70 grams per liter, and their primary outcome was infection. So importantly, they pre-specified their escape criteria, whereby the patient would receive a blood transfusion rather than stick to a specific transfusion threshold. So if the patient had chest pain, shortness of breath, dizziness, low blood pressure, unresponsive to fluid, an elevated heart rate under anesthesia, low urine output, electrical or chemical markers of poor oxygenation, a decrease in systolic blood pressure by more than 10% during physical therapy, or if they ever developed active uncontrolled hemorrhage. The average age of the patients in this group was 32. The most common etiologies were motor vehicle accidents and gunshot wounds, and most of the patients had either significant injuries involving 2 or more long bone fractures, or an isolated femur fracture. And the outcome, first of all, they had a really hard time recruiting patients for this study. So they have a big long paragraph in the paper that says that they felt that many physicians actively discouraged patients from enrolling in this study. So it took a lot longer than they anticipated to get to their specified endpoint of 100 patients. They actually had several safety reviews required by their ethics review committee throughout the study period. And at every single review, the restrictive group had fewer complications and fewer infections than the liberal group. But the study was allowed to finish because the liberal group was the standard of care. So lo and behold, we now have a randomized clinical trial evidence that transfusion thresholds as low as 55 grams per liter in the orthopedic trauma population are at least as good and possibly better than a threshold of 70 grams per liter when the patient is young and otherwise healthy, which means that AABB paper already requires an update statement. So this paper was another retrospective cohort study, not included in the AABB review and recently published. And they used a dose-finding approach to find ideal transfusion thresholds in frail geriatric patients. They used a composite outcome of MI, stroke, arrhythmia, or death. And overall, what they found is 70 grams per liter was equivalent to 80 grams per liter overall. But when the hemoglobin was less than 70 in the frail orthopedic geriatric population, they did see a significant increase in complications. Specifically, atrial fibrillation was the most common. And one thing I wondered about that I could not find in this documented in this paper was whether or not patients whose hemoglobin went lower received more crystalloid than those whose hemoglobin did not, and whether this contributed to the higher rates of atrial fibrillation, but that wasn't mentioned at all. They also did something else that I thought was clever, and they divided up the risks by adverse outcome, hemoglobin level, age, and physical status of the patient. So the overall adverse outcome rate was 6.1%. And then when you compared less than 7 versus greater than 7, it looks like there is a difference. But if you stratify by age, those with age less than 79 and a hemoglobin less than 71 actually had the same overall adverse outcomes as those whose hemoglobin was maintained higher than 71. And again, they stratified the highest risk group of age over 79 and low hemoglobin by ASA status score. And you also saw a doubling of risk if the patient had a high ASA score. So how does that jive with other randomized control trial evidence that we actually have? So this is one from cardiac surgery. And they found that the only thing that affected risk was actually in the opposite direction. And the patients who were elderly, specifically those over 85 and maybe even over 75, actually did better with a hemoglobin threshold of 75 grams per liter. Again, very recently, this was the MINT trial that was published in patients with active acute myocardial infarction, comparing 80 to 100 grams per liter. And they were unable to show a statistically significant difference between the two groups. However, we're never content to stop there. So when they looked at the subgroup events, they found that 100 grams per liter might be better if the etiology is a type 1 MI, the patient has low ejection fraction, or if they have kidney failure, but they're not quite on dialysis yet. And I always have to refresh my memory because when they changed the nomenclature on this, I always have to look it up. Type 1 is the acute plaque rupture. So you basically don't have time to have physiological compensation. And this is the group that might do better with a higher hemoglobin. The other group, so the type 2 infarction, so this is where it comes down to oxygen supply and demand. They actually do as well with the lower hemoglobin. And this doesn't, again, the nomenclature is based on catheterization. So ST elevation MI can still happen in a type 2 myocardial infarction. And specifically, so illnesses might increase oxygen utilization, as may an acute disease process like a femur fracture and surgical stress, or progressive anemia might result in reduced oxygen carrying capacity. And this is where collateralization that might develop over time might be protective. And this is might be why the reason that this group shows differences. So in the type 1 MI, they have less acute reserve. In the type 2 MI, it might be more sensitive to other flow characteristics, some of which we've discussed, including RBC morphology and the biochemical composition of blood with 2,3-DPG and nitric oxide, which promotes oxygen offloading to the tissues. So we already know, at least in both Canadian and UK studies that have been done, is the most common way that we transfuse patients is via hemoglobin number alone, and that's probably inadequate to address a patient's needs. So we know that age matters, physical status of the patient matters, the type of ischemia seems to matter, and transfusing based on a hemoglobin alone is probably an inadequate way to take care of our patients. So we're going to come back to case 1 here and just knock this one off the checklist. So this patient was previously healthy. She was anemic to start with, but again, this happens all the time. Anemia is often overlooked. This morning, there was a talk from the pre-admission clinic group, and I noticed on the screening thing there still was not a piece looking at anemia on that. It just tends to be missed a lot of the time, and there's no further workup of what type of anemia this patient actually had. Her hemoglobin dropped by 50%, but she still actually is clinically stable. She's going for operative fixation. And according to the newest study that's out there, the best transfusion strategy for this patient is to transfuse less than 55 grams per liter or when she becomes symptomatic. And there should be no reason for anesthesia canceling her when she goes to the operating room. We're going to talk about the other management that would be considered ideal in the upcoming slides. So I'm going to start with a comparative story. And again, coming back from France, the Tour de France has been going on for more than 100 years. Up until 2012, no British cyclist had ever won the Tour de France. Over 100 years of trying and literally no wins. So they hired a new coach, Sir David Brailsford, who created Team Sky. And he said that a British cyclist would win the Tour de France within 5 years. Of course, people thought he was crazy until they won it in 2 years. And then for good measure, they won 5 out of the next 6 races as well. So how did he do it? He looked for all the tiny places where he could make small improvements, things that would never win a Tour de France on their own. Things like making sure the riders' uniforms were always washed in the same skin-friendly detergent. Things like making sure the riders always slept on the same mattress, which meant transporting them from hotel to hotel. Things like making sure the rooms were always vacuumed right before the riders arrived, or that the riders always washed their hands in a very specific way, even pre-COVID, to prevent infection. These were tiny little things, nothing that you would say, oh yeah, that's why I won the Tour de France. But when you aggregate and compound enough tiny things, you can actually say that magic happens. In this case, it was Tour de France wins. So as Brailsford put it in his book, he realized early on that having a grand strategy was futile on its own. You also have to look at the smaller level, figure out what's working and what isn't. Each step on its own might be small, but the aggregation can be huge. So what does this have to do with patient blood management? Adding one thing to your toolbox is good, but if you have a complete armamentarium, it's even better. Incrementally adding every improvement and removing harms and hindrances that would improve the patient's care journey will remarkably improve patient outcomes. So we'll start with one of the most commonly studied medications in hemorrhage and trauma, tranexamic acid. It's been shown to reduce blood loss and improve mortality. And despite thousands of patients in these trials, it's actually failed to show an increase in thrombotic complications. And it's cheap. Compared to the other tools we will talk about, this one is easy and feasible to implement immediately. But it needs to be given early. So ideally, it would be given within a few minutes of when a diagnosis of a bleeding event. In this case, ideally, it would be given at the time of femur fracture. And again, going back to the study on preoperative anemia and blood transfusions in patients with hip fracture, tranexamic acid does significantly reduce transfusion in hip fracture. The other one, and this is one of the reasons I think we're together today, is team-based approaches to take care of these patients actually improves outcomes and decreases mortality. So this was from the UK. There's been other studies from the US that have verified the same thing. It coincided with what they called a best practice tariff, which meant that you had to meet all of your team-based measures, including fall assessment, early surgery, a complete nutritional assessment, delirium and mini mental status test, and early physiotherapy. And again, using a team-based approach seems to decrease mortality and improve outcomes. Along those same lines of team-based care is optimal anesthesia. This probably also includes the use of preoperative regional anesthesia for reduction of fracture pain while the patient is awaiting surgery. But I think this has been covered in the previous rounds, and it's more than I can get into today. So good pain management might also influence fluid management, which we'll explore a little bit more in one of the next tools. Anesthesia choices do seem to affect blood loss, perhaps partly through differing vasodilation caused by systemic or inhalational agents, and also the maintenance of spontaneous ventilation. I suspect that given the studies on early DOAC surgery, that most patients who are on anticoagulation that are operated on early will receive a general anesthetic, and TIVA is probably the modality of choice in this population. One thing that's important to note, though, is that when hypotension is encountered and felt to be most likely due to vasodilation, otherwise known as distributive shock, that it be addressed with an appropriate vasopressor and just the right amount of fluid, which is in itself probably another talk. Again, as Scott alluded to, the surgeon also matters. So the higher surgical volume that a surgeon has generally results in a shorter operating time, which results in less blood loss, which it doesn't mean rushing. It just means that in general, experience leads to efficiency. Tool number 6 is temperature management. We don't routinely pre-warm patients who are injured and on the ward, particularly if it's deemed to be a short case such as a gamma nail. It's actually a privilege that we somehow allowed only our elective surgical patients to have routinely. However, as little as a drop in 0.8 degrees Celsius can increase blood loss and transfusion risk. This is certainly a marginal gain that would be relatively easy to improve. As well, does anybody know of have a grandma who doesn't complain of cold feet? Even with the broken femur, you can make someone's day by warming them up preoperatively. Another one that, again, is seldom used in the orthopedic population, but often in cardiovascular or vascular surgery, is cell salvage. So interestingly, the cost of a setup for just collection of blood is basically a heparinized bag of saline and a collection system is about $25. If enough blood loss happens during the surgery, the remainder of the cell salvage system and centrifuge can be set up to return the blood to the patient, which is about another $100. The caveat is that it does need to be from a clean surgical field. Interestingly, what this study shows is that the blood that's returned to the patient from their own body is actually a better quality product than what is provided in stored blood bags. In particular, the fresh blood returned to the patient hasn't yet lost its 2,3-DPG, which is one of the factors that's depleted in stored blood, which means the blood that's returned to the patient has a better ability to give oxygen to the tissues. What they did in this study is they actually followed the 2,3-DPG levels for the next 3 days. And if you received a blood transfusion at any point in time, it actually suppressed 2,3-DPG levels for at least the next 3 days, which is when they stopped the study, compared to the group who had blood returned to them that actually either slightly increased or maintained a baseline value of 2,3-DPG and therefore oxygenation of the tissues. So we're going to go into a few more of these tools in depth. Optimizing iron status is probably really important.
Sorry, Ryan, I'm just going to interrupt you for a second.
Yeah.
For those that have to go to 8:30, I just want to see if anybody has any questions. And if you have any questions, please put them up and then we'll just finish your part as well. I just being aware of people's time and people that are able to stay, please stay. So any questions from anybody so far? And I don't see anything on the chat. Okay, thanks, Ryan. And again, people that might have to leave might leave, but those that can stay, please stay because the rest looks pretty amazing. So thanks.
Yeah, sorry, this is always the problem of coordinating 3 people who haven't had a chance to sit down. And a big part of that is my fault for traveling beforehand. So erythropoietin is, as I mentioned, synergistically beneficial across with the use of IV iron or oral iron Protein intake is very important, and a significant number of elderly patients are probably deficient overall. All of your B vitamins and copper play a role in the production of red blood cells. And sometimes we measure B12, but we usually don't measure anything else. Measuring folate is expensive and time consuming, and it's actually cheaper to just supplement it. Thyroid hormones are often normal and can be considered. And lastly, there was a recent trial called the Traverse trial that had a subgroup of patients who are anemic who were supplemented on testosterone, and lo and behold, they got better. And I would refer you to that study if you want to know more about testosterone supplementation in an elderly, frail male population. So this meta-analysis was interesting because they actually showed that IV iron actually had a decrease on mortality, which was interesting to me because this is one of the first times I've come across that. Usually we see a decrease in readmissions or increased quality of life, but this was actually showed a decrease in mortality as well. It also showed a significant decrease in the level of transfusion provided to the patient. So we know that iron is in blood. For every 1 milliliter of blood that's lost, you have about half a milligram of iron that's also lost at the same time. So if you were to calculate this for a male patient, they're going to be iron deficient if their hemoglobin is less than 110 grams per liter. In a female population, using slightly different values, which is probably a little bit unfair to the female population, probably we should be using 130 grams per liter across the surgical population. It's going to be about 100 grams per liter, and they're going to be iron deficient. Another way of phrasing this is any blood loss that happens during surgery that's greater than 1 liter, they're going to end up iron deficient. So we have a simplified anemia screening checklist that we use at our pre-admission clinic. Anything less than 120, they get iron studies. The interesting thing is ferritin by itself, especially in an elderly population, is probably useless. And there's been a couple of studies published in the last few months showing that in elderly heart failure population, it probably shouldn't be done or used at all. And then we have to rely on the TSAT, which is probably more accurate in the elderly population. If the TSAT is less than 20%, you'd start with IV iron. And if the TSAT is higher than 20%, you'd probably start with erythropoietin. But the thing to know about erythropoietin is it'll drop your iron stores by about 50% in less than 1 to 2 weeks. And so you need to follow the iron studies while they're on erythropoietin and adjust iron as necessary. There is an IV iron inpatient order set that's available across all of the SHA now, and coverage is available for inpatients across the board. It's relatively simple to fill out. You have to fill out that they're anemic. You have to fill out either an iron study or a blood loss piece. And in the case of operations, it's easy to just check off the perioperative piece. The most common one that we should be ordering for most of these patients who are greater than 50 kilograms is the ferric maltose 1,000 milligrams. So what happens when you combine some of these tools? We've looked at tools in isolation, and most studies try and do this in isolation as well. But when you start to combine them, you actually take advantage of the pharmacological effects of more than one piece. So again, this is a hip fracture study. The patients were predominantly over age 80 and predominantly female, and they had a 50-50 blend of intra and extracapsular hip fracture. TXA was given as a 1 gram bolus and 1 gram over 8 hours at enrollment, which was about 24 hours after the time of injury. But at least 25% of patients were delayed 48 hours until inclusion of the study. So interestingly, this TXA was given preoperatively. Then, at the time of surgery, which is about 48 hours on average from the time of hospital admission, another 3 grams of tranexamic acid was diluted to an average or total volume of 120 mLs, and 60 mLs of this solution was irrigated at the time of the device insertion, and another 60 mLs was irrigated immediately prior to closure. They alternated IV and topical to avoid systemic complications such as seizures, which have been found when doses exceed 50 milligrams per kilogram of intravenous TXA. So looking at the times that they used on this study of about 24 to 48 hours, I think we can at least replicate their timing and possibly improve it, particularly if our admission order sets for hip fractures, which is often completed in the emergency department, includes tranexamic acid and IV iron. We might also be able to do even better if our sending sites, including EMS and referring hospitals, are able to administer TXA when they make the diagnosis and send them into Regina or Saskatoon. IV iron was also infused at the time of enrollment to the study. So again, preoperatively, which was again on average about 2 days prior to the surgery. And again, just repeating that ferritin piece, most of these patients, if you did ferritin alone, you might be convinced that their ferritin levels were normal. But if you looked at their percent saturations, almost 65% of these patients had a low percent saturation and would have qualified for IV iron. When you combine the two groups, the IV iron plus the tranexamic acid, there was a 50% reduction in blood transfused. They actually stopped this study early due to reaching a positive endpoint, but the isolated efforts of either TXA alone or ferric maltose alone didn't show a significant reduction in transfusion overall. And part of this can be explained by when you look at the timing of when these medications actually worked. So TXA in the TXA plus placebo group worked early to reduce transfusions. And the IV iron plus placebo group, when you looked at the day 30 mark, reduced transfusions, but it was late. And so when you combine the two groups, the ferric maltose plus TXA, you found that across the entire patient journey, they had a lower transfusion risk overall. Their other 90-day outcomes that they had, they didn't find a difference, but they felt that maybe they would have seen a difference if they went on to complete the study completely, but again, stopped it early because of reaching a pre-specified endpoint with transfusion. So we'll move on to erythropoietin just briefly, because I know it's not covered right now. I think it's worthwhile considering in select populations. It's probably underutilized, especially in our trauma population. A big part of the problem, again, is that cost, in that it's one dose of a weekly dose of erythropoietin is about the same cost as a unit of red blood cells. But its biological effects appear to be in part able to stimulate hemoglobin production and in part able to directly stimulate cells that prepare for hypoxia, similar to something else we sometimes do in anesthesia called pre-ischemic conditioning. It's been used in hip fractures, which has been shown to reduce transfusions by 50% as well. In arthroplasty preoperative pieces, it's also been used, which reduces transfusion by almost 60%. And we looked at it in trauma, it actually reduces mortality, which is still maybe not widely practiced and didn't show up when Cadith reviewed the use of erythropoietin perioperatively in 1998. In 2009, even, this was a previous meta-analysis from the Journal of Trauma that showed that there was 4 factors that improved mortality in trauma patients: being cared for at a trauma center, being cared for by patients, or pardon me, providers who were skilled in ATLS, early damage control surgery, and erythropoietin. Again, 2019 meta-analysis from Anesthesia and Analgesia demonstrated reduced transfusions, and that at that time there were 32 randomized controlled trials confirming its use and safety in the perioperative period. In Saskatchewan, we cover erythropoietin for our acute renal failure patients and our patients with HIV. On the graph on the left, the x-axis shows an inadequate response to anemia to drive erythropoietin production. And on the graph on the y-axis, pardon me, it shows what the patient's responsiveness is when exogenous erythropoietin is provided. So renal failure is the quintessential case of no EPO, but they're responsive. HIV is actually way down on that list, on the axis in both directions. But when Cadith made its review in 1998, it had strong advocacy because at the time in 1998, HIV was, we were still having problems treating it in a lot of ways. And it had a strong patient advocacy that included it in the coverage for coverage across Canada and in Saskatchewan. So it's interesting that there's 2 relevant groups to the orthopedic population that actually show a better response than HIV, and that's the rheumatoid arthritis population and multiple myeloma populations. And arguably, not every cancer patient is the same, and some who have shown higher recurrence with transfusion may actually benefit from erythropoietin use as well. The cost of erythropoietin, so in 1998, it was considerably higher than a blood transfusion. But relative to inflation, it's actually come down, whereas transfusion has actually increased relative to transfusion. And the specified dose in 1998 of 20,000 units was $158, which translates into $300 at today's value. And our actual cost of that dose is approaching where it is actually cost feasible. So it makes sense to at least consider it in some of our patients, such as those with trauma, severe anemia, possibly some cancers going for surgery, and rheumatoid arthritis. It is actually available, but it does unfortunately require additional paperwork to fill out. This is the form. We use it in our pre-admission clinic. The patient usually still pays for the cost of the drug up front, but it can be reimbursed and needs to be faxed to the company that provides it. I mentioned fluid management just briefly before, and fluid management is always fascinating because as soon as you add fluid to a patient, you can make them anemic. This is a study in healthy volunteers, and basically show that any fluid bolus greater than 10 mLs per kilo will decrease hemoglobin by about 10 grams per liter or more. But that 10 gram per liter drop will be maintained for probably a few days afterwards, probably 3 to 5 days to completely clear out the fluid that was bolused to the patient. As patients develop inflammation, more of this fluid extravasates and the effect on hemoglobin concentration is less, but edema actually limits the diffusion of oxygen to the tissues. So if your patient is able, oral clear fluids are probably preferable to IV fluids, both in terms of maintenance and bolusing. And this is an area where hospital systems haven't caught up yet because we've made it easy to bolus patients, but not able to provide other means of changing blood pressure, such as a little ephedrine bolus or phenylephrine infusion. And it's important because the causes of distributive shock are probably much more varied and much more common than simple hypovolemic shock. And this is, again, as I alluded to, in an area where regional anesthesia might affect fluid status, whereas systemic opioids lead to systemic vasodilation, and our current medical system only permits us to respond to calls of low blood pressure with more fluid boluses. It would seem like this area is an area ripe for study because so far I haven't seen this aspect of regional anesthesia reviewed. We're starting an anesthesia program in Regina, and maybe this is an area of study that I'll be able to find somebody to actually take a look at. One more aside is that just because fluid stays intravascular doesn't mean it changes or improves outcomes. So this is a meta-analysis in surgical patients for the use of albumin, which actually showed increased dilutional anemia and coagulopathy, but overall did not change outcomes. So the recommendations from the international community, which also has a strong Canadian voice on this committee, on transfusion, is that albumin be avoided in surgical patients. At 70 times the cost, you can achieve the same outcomes with albumin. So it's recommended to not use it. Probably one of the more important things is leaving blood in the patient, and this ties in well with Oksana's talk. We need to change how we tend to round on patients using routine blood work rather than on patients themselves. Rounding on labs makes our lives easier, but it doesn't lead to better outcomes. And in fact, our desire to always know the hemoglobin concentration or the sodium or the INR PTT actually leads to adverse outcomes. The more blood you take, the less you leave the patient to recover with. The 20 mLs of phlebotomy that happens with the average blood draw adds up quickly to make patients anemic. The most common cause of anemia in the hospitalized inpatient is medical providers, so we need to be cautious about when we order and how we order our blood work. So in summary, this patient is 78 years old. The optimal transfusion strategy is probably somewhere in that 70 to 80 grams per liter. And it's probably okay to wait until the patient is symptomatic, as long as they're somewhere in that ballpark of 70 to 80 grams per liter. You really need to consider the patient factors and how they're tolerating anemia before initiating into blood transfusions. The other tools, as I'll summarize, are still very important and lead to incremental improvements in patient care. Some of this we could implement quickly, and others, such as providing erythropoietin, will probably take a little bit more time. The overall strategy should include efforts to leave blood in the patient by reducing phlebotomy and early operative care to reduce bleeding time with bleeding bone. We should probably be using IV iron and TXA in combination preoperatively in all of these patients. We should pre-warm the patients, and we should at least have a cell salvage collection system set up when we expect blood loss or if it's new to our practice and we're operating on patients on DOACs earlier than we're more comfortable, it might give us that extra feeling of safety that we can return the blood to the patient if bleeding is encountered. Perhaps most importantly, including a team-based strategy to take advantage of individual strengths and knowledge is critical to improving patient care, particularly as medicine becomes increasingly complex. So I'm going to go finish with the Tour de France again, and just to say that incremental improvements work together to improve patient outcomes. The principle is to leave as much blood in the patient as possible, and these are the tools that we have at our disposal to get there.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.